So rather than having me talking all the time, we will concentrate in herpetic eye disease, okay? And I want this to be an interactive session. You know, with the lecture, the average retention of knowledge around 10%. And if we do a group discussion, it goes up to 50%, okay? So I don't want it to be Majed centered, rather I want it to be participant centered, okay? So there are more than 130 subtypes of herpes virus. And the word herpes derived from a Greek word which mean to creep. And the first herpes virus discovered was in 1961. And they noticed that the herpes virus travel across the nerves, and that's why they gave it the name heparin, or to creep. It's a double-strand DNA, and it's enveloped, which make it vulnerable to damage. And that's why herpes virus and HIV viruses are very fragile and weak outside the host, compared to adenovirus, which is non-enveloped, which can last up to weeks in the outside the host. There are, as I said, there are more than 130 types of herpes virus. Some will infect only humans, other will infect certain types of animals. We will concentrate our talk on herpes virus simplex 1 and 2, which is the most common to cause eye infection. So as we said, we want this to be a group discussion rather than a classic lecture. So we want the junior resident to start the discussion. And what do you know about herpes simplex virus? Otherwise, I'm going to point names. المشكلة إني ما أعرف إلا زياد أنا. Ziyad, do you want to start? Like, what do you know about herpes simplex virus? Basic knowledge. Excellent. Okay, so to start with, we have herpes simplex 1 and 2, and usually 1 will infect above the waist, cause infection above the waist, and type 2 will infect below the waist. Do you think it's possible to have the same ganglion infected with more than one herpes simplex? Iman? Okay. It's possible. Sometimes you can have herpes simplex 1 and 2 coexist in the same ganglion. Okay, not even that. You know, there is more than one strain, and the same ganglion can be reinfected with other strains. And you know, there is some strains which will cause more of epithelial keratitis, and other strains will cause more of a stromal keratitis, and some strains will be resistant to certain antivirals, and other will be sensitive. And that's why it's very difficult, Zain, to have a vaccine for herpes simplex viruses because of the multi-infection and reinfection. However, once the infection occurred, the virus will stay latent in the ganglion cell, okay? And most of the time, we will get the infection during childhood, and less than 5% only will be recognized as a primary HSV infection. Why? Because you know, you will have an upper respiratory tract infection like a flu, and neither the family member or the physician will not recognize it as an HSV infection. If you pay extra attention, you might see 1 or 2 vesicles, but however, most of the time, it will be recognized as a primary infection less than 5% of the time. Herpes simplex is very common. You know, if I take a blood sample from this group, around 80% will show some positive titer of HSV. And in one study, they found people above the age of 60 in autopsy, 100% they found the herpes simplex in the ganglion nuclei. So what will make the virus to reactivate? Like, what are the reasons to have the virus become active again? Anyone? As I said, we want this to be an interactive session rather than lecture-based. So even if you say something wrong, that's fine. Go ahead, Abdurrahman. Excellent. So, excellent. So what Abdurrahman mentioned, things that will make the immunity a bit weak, okay? And he mentioned something else, which is ultraviolet. You know, ultraviolet will cause some oxidative changes in the human cell, and this will cause some damage. And this might lead to reactivation of the virus. And that's why people who go for skiing, they will come back with pain in their eyes, and they found to have an epithelial defect. Why? Because of the ultraviolet will cause some oxidative changes and death of cell. However, all the risk factors that Abdurrahman just mentioned was not confirmed in the HEAD study. The HEAD study, it's a large, it's one of the only anterior segment wall structured study, herpetic eye disease study. And they would try to see if there is really a risk factors for reactivation, and they looked at all the factors that Abdurrahman just mentioned, and it's not proven to be a cause of reactivation. However, from clinical practice, we know that these risk factors can trigger HSV, and this is well known also in dermatology, like with some sort of stress, systemic illness, the virus will reactivate. Any questions so far? Okay, so you know, we talked about reactivation of the virus, and if the virus will stay dormant in the ganglion cell, and it will travel across the axons to the infected site. Do you think it's possible to have patient with, let's say, V3 to have an herpetic eye disease in the future? Or it has to be V1? Huh? It can be. Excellent. Most of the time, if you have, let's say, herpes labialis, you will get the same reactivation of the infection at the same location. However, sometimes you can get herpes labialis or even infection in the chin that will lead to herpetic eye disease. Okay, so it's very important when you are taking a history to ask if the patient had some sort of skin lesion around the mouth or even in the chin. So the primary infection or the primary ocular infection, most of the time it will be blepharoconjunctivitis. I will ask you, Abdurrahman, again, because maybe you are the only one who's talkative this session. What do you know about primary ocular infection? Like, what do you think will happen, what the patient will present with? Excellent. What type of conjunctivitis? Excellent. Do you think the patient will have stromal keratitis? Excellent. And why no? Excellent, excellent. So, correct, Abdurrahman. In the primary ocular infection, mainly you will have blepharoconjunctivitis. It's very rare to have stromal keratitis because stromal keratitis is it's an immune-related disease, and you need to have the virus dormant in the ganglion. As we mentioned, with the reactivation, the virus will travel across the axons toward the cornea. That will lead to reactivation and keratitis. However, if you have a primary infection, still the virus did not get to the ganglion cell. It's only in the eye surface. That's why you will have only blepharoconjunctivitis and some sort of epithelial keratitis, but it's very rare to have a stromal or uveitis from HSV. And sometimes you cannot really differentiate between primary or recurrent blephroconjunctivitis. However, sometimes you might see lymphadenopathy with the primary conjunctivitis rather than recurrent blephroconjunctivitis. And sometimes we see patients with follicular conjunctivitis, and we will diagnose them with the most common, which is adenovirus. However, if you have patient with recurrent follicular conjunctivitis, think about HSV. What are the differences between adenovirus conjunctivitis and HSV conjunctivitis? Very contagious. You mentioned unilaterality, which is a very important hallmark in diagnosing HSV keratitis. However, sometimes you can get bilateral disease in certain type of people. Do you know it, Iman? Or anyone? With what? Immunocompromised. It's some sort of immunocompromised, but not immunocompromised by itself. Patient with history of atopy. Why? Because they have problem with the T cell mediated immunity, and this make them more prone to have staph and herpes infection. And in the head study, around 3% of the patients developed bilateral disease. And one more thing that might help you to differentiate between adenovirus conjunctivitis and HSV conjunctivitis is a membrane or pseudomembrane. It's very rare to have membrane in HSV. It's possible, but it's very rare. Okay. So as I mentioned, the primary infection mainly peripheral conjunctivitis. Sometimes with the recurrence you can get blephroconjunctivitis as well, and you cannot differentiate it from the primary infection. And we talked about the reason for recurrence, and we said if you have V3, you might still get a V1 infection. Okay. HIV patient tend to have more recurrent disease. However, the severity of the infection is similar to non-HIV patient, which means that the HIV patient tend to have more recurrence, but the severity will be similar. And there is controversy if the virus itself will stay dormant in the cornea only, or in the ganglion cell. It's very documented to have the virus in the ganglion nuclei, but some were able to identify the virus in the cornea as well. Recurrent herpetic eye disease can affect any ocular tissue, and it's a very common disease. The risk of recurrence around 20%. And actually, it's one of the common causes for blindness in the United States from infectious etiology. And patient with history of herpetic eye disease, 1/5 of them will have stromal disease, which is a very devastating disease to have, and it's one of the morbidity factors for herpetic eye disease. In contrast with zoster infection, the morbidity will be from iridocyclitis rather than stromal keratitis. So we will divide our presentation into, we already talked about blephroconjunctivitis, so we will do epithelial disease, stromal disease, and iridocyclitis. And this is the most common clinical presentation of recurrent HSV infection. So epithelial keratitis. Again, I need another volunteer to mention one or two facts about HSV epithelial keratitis. عبد الرحمن الضراب شفتك في الصلاة. هذا. Anything you want to mention? Anything you know about HSV epithelial keratitis? Do you think it's an infection or an immune reaction? Excellent, excellent. This is a very important hallmark of epithelial keratitis. You have an active infection in the cornea. That's why you can have a seat, Abdurrahman. That's why we treat it with antiviral medication. So the most common presentation for epithelial keratitis is a dendritic ulcer. And it's very important to differentiate between dendritic and pseudodendritic because the causes are different, okay? And Abdurrahman mentioned that the dendritic ulcer have a terminal bulb. And maybe this will take me to the next slide, and I will go back to my first slide. You know, when you have an epithelial defect, let's say 5 by 5 millimeter, from any cause, trauma, let's say, and you see the patient next day, what do you think will happen to this epithelial defect? It becomes smaller. And anything specific regarding the edge of the epithelial, of the healing epithelium? Loose attached. Okay, what else? Huh? You mean from all aspects it's gonna grow and close the defect? Yes. And why is that? Excellent, excellent. This is because of the migration of the stem cell. You know, the stem cell will regenerate the epithelium in a centripetal configuration, like hurricane-like configuration. If you have a 5 by 5 millimeter of epithelial defect, the normal stem cell is still working, and it will invade the defect from this aspect, and it will give you a convex margin to the healing epithelium. Once you see this sign, you can be sure that this epithelial defect will heal. Why? Because you have stem cell that growing in all 360 degrees. However, you know, sometimes we have patients with neurotrophic corneas, which means that there is no enough lubrication, Zain, or sometimes patient with a stem cell deficiency. And the hallmark of this ulcer or this persistent epithelial defect, it will be an oval shaped epithelial defect. And why it's oval? And where is the location of the ulcer will be usually? Excellent. So it will be at the junction between the lower third and the upper 2/3. And why it's oval? Huh? Lid movement. It's something related to lid, but not the movement. You know, huh? Exposure, excellent. So you know the horizontal meridian will be of the cornea will be exposed more to air, and it will lead to more exposure keratopathy compared with the vertical meridian. And even if you look at the palpebral fissure, it's more exposed horizontally. And that's why we have an oval-shaped epithelial defect. Same? So if you have a healing epithelium, it can give you a pseudodendritic ulcer, which is a branching ulcer that will mimic HSV. But Abdurrahman mentioned that HSV dendritic ulcer will have terminal bulb, which means that this aspect of the defect will be slightly swollen and large. And why is that? You know, usually when we have HSV infection, Zain, not immune-related infection, the virus will infect the human cell, then it will go to the nucleus, and it's going to utilize the nucleus resources for his own benefit. It's going to use the nutrient, enzymes, etc. to cause replication. Once the cells are infected with the HSV, it becomes sick, Zain, or any virus, it becomes sick. With time, Zain, the cell will rupture, and all the virus will escape from this cell to escape another cells, to go to another cells. طيب. So at some point, you will have a sick epithelial cell that with time will die, and it will rupture. The reason for the terminal bulb, because you have a sick epithelium in this area, Zain, and it will try to expand even more. Compared with the healing defect, there is no problem with this edge, and that's why there is no terminal bulb. Zain? طيب, let's go back to the epithelial keratitis. Again, the most common presentation of HSV epithelial keratitis is a dendritic ulcer, and it's a true ulceration, which means that there will be missing epithelial cell and exposed basement membrane. You know, sometimes you might lose some of the epithelial cell, but not all of it, Zain, and this will not call it an ulceration. Once it's invaded the basement membrane, we will call it an ulceration. It's common to see sometimes with dendritic ulcer some sort of a stromal edema and early stromal haze, but this is not stromal keratitis. This is just a reaction to the epithelial keratitis. Okay. Any questions so far? Clear? طيب, what's the treatment of the dendritic ulcer, عبد الرحمن? عبد الرحمن الزيدة وعبد الرحمن الظلمة. First of all, do we have to treat it? Why? Excellent. So why do we treat it if it is a self-limiting disease? Excellent. Iman mentioned here to shorten the duration. What else? Which is the course of the disease? Ahsant. Excellent. Excellent. So Mohammed al-Dawsari mentioned that if you treat epithelial keratitis, this might decrease the neurotrophic sequela of HSV epithelial keratitis. Other reasons is when you shorten the duration, you will get rid of the virus very quickly before it causes any inflammation or infiltration of the stroma, and this will decrease the chance of a scar. Same. Usually after dendritic ulcer, you will get a ghost-like or footprint scar which resemble the previous dendritic ulcer. Okay. So I mentioned here rose bengal and lasman green. Anybody knows what are these two stains? And for what do we use it? Excellent. So it stains sick epithelium. What else? Cell that infected with virus, devitalized cell. And actually it can stain any cell that are not covered with a mucin layer. You know, the mucin will be secreted from the goblet cell. Actually, it will be excreted, so it will be excreted outside the cell to the tear film. However, the conjunctival and the epithelial cell has the ability to secrete some mucin 1 and 4. And this mucin will stay at the cell membrane, so it will not leave the cell. If you have chronic dryness, medicamentosa, or any infection, this mucin will be gone, and the cell membrane will be exposed. And the lasman green or rose bengal can stain any cell that's not covered with a mucin. What are the differences between lasman green and rose bengal? Go ahead, Mohammed. Excellent, excellent. So rose bengal is a bit toxic and more irritant to the eye. And the other thing, if you are planning to take a culture, you should not use rose bengal because it will kill the virus because of the toxicity. Other uncommon presentation of herpetic epithelial keratitis is corneal vesicles. You know, it's similar to the skin eruption that you see in the skin. However, it will be localized to the corneal epithelium, Zain. And you can get the vesicles within 24 hours of the infection. And with time, these vesicles might coalesce and it can give you the dendritic ulcer. So if you have a patient that he's known to have epithelial keratitis in the past, and he came to you complaining from pain, photophobia, think about recurrence if you see this vesicles. And actually, this is the perfect timing to treat epithelial keratitis. Abdurrahman, I don't know if you mentioned it or not. It's a self-limiting disease, but sometimes we removed the epithelium, and the idea is to get rid of the virus. However, you still need to give antiviral. What do you think, Abdurrahman al-Zaid? Should we give topical or systemic antiviral? Topical. Do you think systemic will work? Yeah, systemic actually will work as effective as the topical antiviral, and the advantage of the systemic antiviral that you don't have the toxicity that comes with the topical antiviral. However, it make more sense to give topical antiviral because you have the virus in the surface, okay, in the surface of the cornea. So it makes more sense to give topical antiviral. Other uncommon presentation of epithelial disease is marginal keratitis. Anyone heard about it before? I'm going to discuss it in details in the next slide. So we mentioned that we can give topical and systemic antiviral, but I mentioned here that you can get thrombotic thrombocytopenic purpura or hemolytic uremia syndrome. Why did I mention this in the treatment? Excellent, excellent, mashallah, excellent. So when you give a valcyclovir in immunocompromised, you need to be careful because this can cause some autoimmune reaction and hemolytic uremic syndrome. What are the sequelae of herpetic epithelial keratitis? Like what will happen next? Someone mentioned scar, dendritic or ghost scar. What else? Geographic ulcer. When you will get geographic ulcer? Excellent. However, you can get geographic ulcer in the initial presentation, and in one study, 2% of the patients that comes with HSV epithelial keratitis found to have geographic ulcer. But most of the time, we see it after steroid. Okay, and that's why sometimes you need to be very careful when you are doing a cataract surgery in patients with history of HSV to cover them with antiviral, or if patients come to you with a pseudodendritic or dendritic ulcer while the patient in steroid, think about herpetic eye disease. Okay, so Iman mentioned dendritic or ghost scar. Excellent. Neurotrophic keratopathy. What are the risk factors for neurotrophic keratopathy? Excellent. So long duration, a frequent attack of epithelial keratitis, severe infection, all of this lead to more neurotrophic ulcer. The other sequela, which is dendritic epitheliopathy. If you see a patient with a dendritic ulcer and you give the patient topical antiviral, usually the treatment course will not last longer than 2 weeks. Like most of the time, the virus will, even in immunocompromised patient, the virus will disappear within 2 weeks. That's why usually we say within 7 days, taper the dose. However, if you have patient continue to use the antiviral medication, they will have a sick epithelium, which is basically the dendritic epitheliopathy. It's important to differentiate between dendritic epitheliopathy and dendritic ulcer, yes. Because if you think that this is still an active infection, you will keep giving them antiviral, and you will increase the toxicity more. There is a test that you can do, and it might help you to differentiate between epitheliopathy and real active infection, which is cornea sensation. We'll come to it in a minute. Staining. Yes, Hassan Abdurrahman. So rose Bengal staining. And actually, if you have a typical dendritic ulcer, the base will stain with the fluorescein because the fluorescein usually stains basement membrane, and the edges, which will be stained with the rose Bengal. So the rose Bengal will outline the dendritic ulcer for you. And also this can help you later on if you see patient with sick epithelium or neurotrophic cornea, and you are not sure, is this an active infection or just a neurotrophic cornea, rose Bengal or lasman green become handy. I mentioned the marginal keratitis as a form of HSV epithelial keratitis. This is uncommon presentation. Usually marginal keratitis caused by Staph aureus. keratitis because of blepharitis, and it's an autoimmune disease. However, sometimes because of HSV, you can have an active infection in the cornea, Zain, with an immune reaction. How to differentiate between marginal keratitis that's caused by HSV versus blepharitis? Usually the marginal keratitis in HSV will have the epithelial ulceration first versus the blepharitis marginal keratitis. Usually the blepharitis marginal keratitis, you will get the infiltrate, then with time you will get epithelial ulceration. However, here it's vice versa. You will get the epithelial ulceration, then you will get the immune reaction. But most of the time the patient will come to you when there is already a stromal infiltrate. Zain? So other things that might help you, so we mentioned the epithelial ulceration. Usually with marginal keratitis caused by blepharitis, there is a clear zone between the infiltrate and the limbus. With the marginal keratitis caused by HSV, usually there is no clear zone, and sometimes you can see new vascularization. The other thing with the blepharitis marginal keratitis, usually you will see blepharitis, Zain. And the other thing, usually the marginal keratitis that comes with the blepharitis, what's the most common location for the marginal keratitis that comes because of blepharitis? Huh? 3 and 9? Are you sure? 2 and 4, 8 and 11 or 10. And why is that? Excellent, because this is the area of contact. Actually, 3 and 9 is away from the lid margin. That's why they will not have the immune reaction. Zain, so to summarize, usually the ulceration would be before the infiltrate in HSV marginal keratitis. There is no clear zone between the infiltrate and the limbus, and sometimes you can see new vascularization. 3, you can see it in any meridian. 4, with the marginal keratitis caused by blepharitis, usually there is a blepharitis. One more thing, with the marginal keratitis caused by HSV, it extends toward the center. Compared with the marginal keratitis that caused by blepharitis, usually it goes circumferential. Zain? And it is an active infection with immune reaction. So the patient needs an antiviral and a steroid as well. So my favorite topic is a stromal keratitis. And as I said, it's actually the cause of morbidity in HSV keratitis is a stromal keratitis. I think Abdurrahman Zaid mentioned that stromal keratitis is an immune reaction, Zain. However, sometimes you can find retained virus antigen within the cornea that led to the stromal infiltrate or the stromal disease. Zain, it's a recurrent, Zain, and each time patient get stromal keratitis, he is at more risk to develop another attack of stromal keratitis. طيب. Do you think, or what type of stromal keratitis do we have? Excellent, excellent. And what do you mean by necrotizing keratitis? But what will happen to the cornea? Excellent, excellent, perfect, excellent. So usually we divide it to necrotizing and non-necrotizing keratitis. Zain, what's your name, by the way? And as Abdullah mentioned, necrotizing, usually it's an active infection. It's not only an immune reaction. There is a live virus within the corneal tissue, compared with the non-necrotizing stromal keratitis, which is usually an immune-related infection. Zain? And usually we divide the non-necrotizing to IK, interstitial keratitis, and disciform keratitis. However, some people consider disciform keratitis as an endotheliitis rather than keratitis, which is accurate, by the way. طيب. Let's take it one by one. We will take the IK, the interstitial keratitis, or the stromal, or the immune-related stromal keratitis. The patient will come to you, again, there is something that trigger the inflammation, and the patient will come to you with a recurrence. And usually the patient will complain of photophobia, pain, decreased vision, conjunctival injection. طيب. Most of the time when you see patient with IK, they had an episode before. طيب. But sometimes you can see IK as a primary, of course it's not a primary, but as initial presentation to your clinic. طيب. Because of missed epithelial keratitis or missed HSV conjunctivitis in the past. طيب. زين. Usually with the stromal keratitis or interstitial keratitis, you will have an active stromal disease. زين. Do you think we will have an epithelial defect with IK? Excellent. Excellent, because it's a stromal disease and it's mainly an immune reaction. So because of the inflammation, you will get some stromal edema and infiltrate. زين. You will get some ciliary injection because there is some inflammation going on, and you will get iritis as well. طيب. Do you think the patient will have KPs? Excellent. طيب. And we will talk in a minute why there is no KPs with IK. But usually it's a stromal edema, stromal infiltrate with inflammation by ciliary injection and some sort of iritis. طيب. Sometimes it's very difficult to differentiate between active IK and a previous scar. And things that might help you to differentiate between these two, presence of edema, and excellent. And the patient will be symptomatic. صح? طيب. You said presence of edema, and how you can look for it. When you take a slit beam, usually with the scar there is some thinning. However, with active stromal keratitis or IK, the cornea will be slightly swollen. زين. And the patient's symptoms. Actually, with time, the patient will know exactly when the virus is active. So you need to take his symptoms in consideration. طيب. Do we have to treat stromal keratitis or IK? Yes. Why? Excellent. Excellent. So it is a self-limiting disease, but we do treat it to shorten the duration. طيب. Decrease the incidence or the density of the scar tissue, and decrease the new vascularization. When there is something cooking in the cornea, with time you will get new vascularization, and this might lead to bad outcome later on. طيب. What's the treatment for interstitial keratitis? Steroid. Excellent, because it's an immune reaction. But do we have to give antiviral? Why? Someone mentioned to cover something here. To cover what? Excellent. طيب. If you give the steroid alone, you might get an epithelial keratitis, which is an active infection. Number two, according to the head study, although Zain, they did not look at the stromal keratitis, the disciform keratitis as a separate group. They looked at the stromal keratitis, the IK, and the disciform as one group. طيب. And they found if you give PO antiviral, will not decrease the recurrences of, or will not to treat the active infection. However, we as a cornea specialist believe that if you give PO antiviral, you will treat the disciform keratitis. And this is something related to the active virus in the anterior chamber, and this what will lead to KPs. I will talk more about it in a minute. I need to go a bit quickly. So herpetic stromal keratitis, it's mainly an endotheliitis that will lead to stromal and epithelial edema. With IK, there is no epithelial edema, mainly stromal edema. However, With the disciform keratitis, you will have stromal and epithelial edema. And it's a discoid in shape. And the reason some people classify this as an endotheliitis, because there is no much of active inflammation in the stroma at the beginning. Later on, you might develop scar, edema, and new vascularization. But at the beginning, it's mainly endotheliitis, and that's why you have the KBs overlying the stromal and epithelial edema. طيب. Do we have to treat stromal disciform keratitis? Yes. Why? Because this will decrease the recurrence rate, this will decrease the long-term damage to the endothelium and decompensated cornea. طيب. One thing which is very important here when you are evaluating patient with disciform keratitis is that the KBs is out of proportion to the cells. زين. And we mentioned why do we have to give systemic antiviral to decrease the recurrence rate and to treat the active infection that's going on at the moment. However, according to this head study, they said that PO antiviral did not add any benefit when you give the patient steroid and topical antiviral, but they did not look at disciform keratitis as a separate group. طيب, necrotizing keratitis. Necrotizing, at what time should I stop? I think at 2. Huh? طيب, we will do this and maybe we will stop. So necrotizing keratitis, it is a suppurative infection and inflammation of the corneal stroma. Do you think we will have an epithelial defect here, as Abdullah Al-Ghamdi mentioned? Yes. Zain. How to differentiate between necrotizing keratitis and bacterial ulcer? Athman? Excellent. What else? New vascularization. New vascularization is very common with necrotizing keratitis. And what Athman mentioned, that usually if you have a bacterial ulcer, the epithelial defect will overlie the infiltrate. However, with the necrotizing keratitis, sometimes you might find it eccentric. Zain? Other than new vascularization, Athman, anything that might help you to differentiate between necrotizing and bacterial ulcer? أحسنت. الhistory. طيب. الhistory is very important. Usually, with necrotizing keratitis, there is a history of previous attacks. Even with the current active infection, usually it's very chronic. Zain, it takes time, and will not respond to the antibiotic. طيب. How should we treat patient with necrotizing keratitis? Excellent. So you need to treat it as a bacterial keratitis at the beginning. By what? By taking culture, start the patient an antibiotic, Zain. And if you have a very strong suspicion for necrotizing keratitis, you can add a PO antiviral, Zain. And one more thing we did not mention. Usually patients with bacterial ulcer, they will have significant pain, Zain. But patient with necrotizing keratitis, the clinical findings or the signs is way out of proportion to the pain. طيب. And this opposite to what? Excellent, acanthamoeba. Usually the symptoms will be way out of proportion to the clinical sign. طيب. So, and why they have less pain? Because the corneal sensation is a bit diminished. طيب. All of this will help you to differentiate between bacterial ulcer and necrotizing keratitis. However, you need to treat this patient as an active bacterial ulcer by taking culture, start the patient a fortified antibiotic, and add PO if you have strong suspicious. Then you will review the culture. If the culture is negative, and you are really sure that this is a necrotizing keratitis, then you can start the patient in a very low dose of steroid while the antibiotic on board. طيب. If there is no history of HSV in the past and you really don't know what you are treating with, it's better to take biopsy before starting the patient in a steroid. Why? Because this could be anything. طيب. So, herpetic iridocyclitis. Who will give the second talk? Do you know? حد يعرف إيمان؟ No? Huh? Grand round? Okay. The speaker for the grand round is here? Huh? He's outside? طيب. ما نبي نصير محترمين. I think I'm gonna stop. I will be more than happy to continue the lecture later on, whenever you have time. We can take some questions. Excellent. We did not talk about the diagnosis of HSV keratitis. طيب. Whenever you are in suspicious, طيب, or you have the facility or the privilege to do culture, طيب. You can take culture, and you can take smear, and you can send for PCR. Smear and PCR very quick. You know, with the smear you will see the dry type 2 geniculate. Okay, I'm done. Huh? You can open the presentation of the next speaker. You can see the giant nuclei. طيب. With the PCR also you will get an active or a very quick response. With the culture usually it takes time. زين. And sometimes if there is certain situation where really you need to take a culture, especially if you are dealing with a neonate or immunocompromised patient or a very complex disease that you don't know what you are treating with. طيب. And especially with necrotizing keratitis, because you will see an active infection. طيب, you will see an active virus. So it's a very good idea to take culture. Adman. Excellent. So the question, when you give PO antiviral, you will give it as a prophylactic or therapeutic. Usually we give for prophylactic dose, because you want to prevent epithelial disease. However, if you are treating iridocyclitis or necrotizing, you need to give therapeutic dose because you are treating infection. I think I'm going to stop, guys. Maybe you can try to find me. And